Good morning, and I'd like to thank the organizers for inviting me. So here I'm going to present about a patient with whom I had a very interesting interaction and treatment. So the patient has agreed to put up his photos and videos for this presentation. So this 32-year-old gentleman from Bangladesh, an ex-bank employee, had been having symptoms of anteromedial knee discomfort since 2012, and he met me in June 2023. He was seen elsewhere, and he had undergone a ligament surgery in 2014, ending up with a stiff knee. So this guy is a keen recreational footballer. He had a very trivial injury from what he says, and since then he has noticed mild discomfort, especially at the end of the day. He denied any instability whatsoever. He meets his local orthopedic surgeon, and he is convinced that the pain in the knee is because of an MRI which showed that he had a partial ACL tear. 2 years down from his onset of symptoms, he agrees for a hamstring-based ACL reconstruction. He had only two requests. He wanted to go back to playing football, to the answer to which the surgeon gave was yes, and he wanted to kneel and pray based on his cultural habits. He did undergo an ACL reconstruction in December 2014, but following the surgery, he was told that he had to make a longer incision because his hamstring graft was too small. He had to end up with a BTB graft, and since his bone was very soft, the knee is going to be protected in a POP cast for 4 weeks. Surprise, surprise, he gets a stiff knee. He gets significant muscle wasting, goes back to the index surgeon who says, the surgery went well, you just need physiotherapy and you will become all right. And guess what? Nothing changed. Maybe there was an improvement in his knee ROM, and according to him, he showed me on his opposite knee that was the kind of range that he improved. He continued to walk with the limp on a flexed knee. There was no improvement in his anteromedial discomfort at all. And now he could start feeling a mild swelling where the pain was. So the next 8 years was difficult for him. He loses his job, he gets depressed, he's now got a reduced knee ROM knee, and he loses his job in the bank. And he comes with hope to India to get this fixed. He ends up in our city. He does seek various opinions across the senior surgeons. His requests were now, I want my knee movement back. I want to go back to work. He wants to play football with his kids. If possible, if he can kneel and pray again, it'll be great. And he has come to the situation where he is not concerned about the discomfort and the swelling. He has had his workups done elsewhere, including MRI scan done in Bangladesh, which was extremely poor quality images. He has had X-rays, lower limb alignment views, CT scan in the centers in Chennai. And he was told he needs a single-stage revision ACL reconstruction using the BTB graft from the opposite side. That scared him. He didn't want his opposite knee to be touched. So he comes to me, and his symptoms are, and his request was, I want my knee movement to be improved. And this was my evaluation. So he had a slight fixed flexion deformity, maybe 1 to 2 degrees or so. He had an active range of movement, which was from about less than 5 degrees of flexion deformity to about 60 degrees. And then I can push him further. It goes up to about 70 to 80 degrees, but then he begins to feel a bit of discomfort. So I do his Lachman's, and his Lachman's is stable. And when I check for his collaterals, it's stable. He's got a reasonably normal patellar glide, which suggests that there is not probably a significant suprapatellar adhesions. But he was a bit tender around the anteromedial aspect of the knee. And that was his X-ray that was done elsewhere. So he's osteopenic, and I can mark out the tunnels. So he's got a femoral tunnel which is completely non-anatomical. A tibial tunnel, maybe we can accept it. So the poor quality images were completely of no value, but it was reported that he had a normal tibial and femoral tunnel, and the reconstructed ACL is normal in intensity, thickness, and position. And of course, it was picked up that he's got now an infrapatellar ganglion cyst. Somebody else has done a scanogram. Is it really warranted here? Because we are not looking at a failed ACL reconstruction here. You're looking at a stiff knee. And especially with somebody who's got a slight flexion deformity, it's very difficult to interpret those. And this is what is CT scan done. The images on the left shows your tibial tunnel position. Looks a bit odd, the trajectory. And if you look at the femoral, it confirms that he's at a completely non-anatomical femoral tunnel, which is shallow and high. And this is the repeat MRI scan. I am not going to say anything about these scans. I want you to infer from these images. I'll give you about 10 to 15 seconds. Please go through these images. So that's your SAG PD fat set. That's your T1 weighted images. So that's your coronals. And that's your axial images. So remember, he has got a swelling. He's had an ACL reconstruction done with biodegradable screws. He has got stiffness. So that's my first ARS. What do you want to do for this patient? I think part of the ARS cuts it off. So about 50% want to do an adhesiolysis and exploration, and the remaining want to do an exploration and a single stage ACLR using a contralateral hamstring graft. Okay. So that's actually how the question looked. So you all seem to kind of want to, a majority wants to go and do a revision ACL reconstruction. So now let's go back to look at the MRI images. So that 44 odd patients missed something. Surgeons, there was a native ACL which was absolutely preserved. And he had undergone a BTB graft on the femoral side with the tunnel being anterior, well anterior to your ACL. So now what's interesting is he has got these lesion which is very close to the tibial tunnel, which was hyper intense on a T2 weighted image and with intermediate signals on a T1 weighted image.